Good evening, everybody. Welcome to tonight's lecture. Vet Education is proud to present a webinar series called The Focus on Recent Graduates. This is kind of a tribute to anyone who has graduated recently and some of you who've graduated not so recently, designed to sort of help us on our journey as veterinarians, regardless of how much experience or how many years it is since we've graduated. Thank you so much for typing in when you last graduated. I see we've got quite a few recent graduates logged in the room this evening and a couple of slightly less recent graduates who are still loving their work, and I think that's just absolutely fantastic for us all to see. My name's Philip from Vet Education. I'm not only your webinar host tonight, but I'm also your speaker, and tonight we're going to be talking about It's an Emergency, 10 things you should know. The reason we're talking about emergencies tonight is, firstly, I'm an emergency clinician. I've been an emergency clinician since 1998. Okay, I graduated actually in 1992, worked in general practice for about 7 years, and then joined the team at the University of Melbourne Veterinary Emergency and Critical Care Centre and did a residency there, and I've been hooked on emergency medicine ever since then. So that's the first reason why we're talking about emergencies. The second thing is that when you're a new or recent graduate, and sometimes when you're a not so new and recent graduate, emergency cases come with a unique constellation of stressors. Okay, there's stressed out clients. Sometimes you're stressed, sometimes the nurses that you're working with can be stressed, and the patient is usually presented to you in some sort of critical situation. Otherwise it wouldn't be presenting to you as an emergency. And so this combination of things, when it's all put together, can put a little bit of extra stress on a new or recent graduate. So I thought I'd just pick on 10 things. There's many, many more things I could have picked on, but I've picked on 10 things that are really just designed to give you a little bit of insight as to what might be going on in many of your patients, maybe a checklist in some instances of things that maybe we don't want to forget as we're working through the diagnostics of our emergency patient. Now, not all of these 10 things apply to every patient that you're going to see in your practice that presents as an emergency. This is a subset of things that I think might be a little bit helpful. Let's kick off. That's me there holding a koala. A few years ago now. I'm a little more grey than that now. It's hard to believe because I'm already grey in that picture. But anyway, let's move on. It's an emergency. 10 things you should know. And I want to know these things as well. The first is about airway protection. I think every course on emergency medicine always starts with airway and breathing because they're so important. If you don't have a patent airway, you can't really breathe all that well. If the airway gets obstructed, the patients can't breathe, they die shortly afterwards. So airway protection is absolutely vital for our patients. And there's a couple of things I want to mention about airway protection. The first is that if we have a patient who presents to us with stertorous, noisy breathing, okay, think the brachycephalic dog sort of snorting, nasally sort of sounds, or maybe a cat with a polyp perhaps stuck in its nasal cavity that comes in snorting, perhaps patients with prolonged noisy inspiration have some form of airway obstruction, and it's our duty as clinicians to try to clear that obstruction and to provide that optimum relief for those patients so that they can breathe a little bit easier. So think nice and early when you have your patients presented to you if they have noisy stertorous respiration and they are in respiratory distress. Think about very early on oxygen supplementation, maybe some degree of sedation even for your patients. And then if your patients fail to improve with oxygen and some mild sedation, maybe analgesia, then we need to consider very early on the notion that we should anesthetize these patients and intubate them. And the reason we're going to do this is severalfold. The first is we're going to be able to bypass whatever obstruction there is in our patient's nasal cavity, its pharynx or its larynx. So, we're talking about diseases, nasal cavity disease, pharyngeal disease, even laryngeal paralysis, for example. If we can bypass these obstructive airway diseases, our patients can then breathe much more effectively. They get better oxygen delivery to to the alveoli. They subsequently get better oxygen delivery into their circulation, and all the body tissues benefit from that additional oxygen delivery to the tissues. So this is something we need to consider fairly early on. So the advice I'm trying to give you is that if your airway compromised patient does not improve with oxygen and whatever other supportive medications that you're giving them, and they have an upper airway obstruction, so an obstruction that is proximal to the larynx, so larynx and proximal to that, then intubate your patient to give your patient a bit of a break, to give them some sort of relief until you can sort out a definitive plan for your patients. So without a patent airway, the patient can't breathe and will die. So we actually need to act pretty urgently to prevent the development of this lethal hypoxia. So as I've already mentioned, providing supplemental oxygen, gently extending the neck and pulling the tongue forward, particularly in patients that will allow you to do this. So patients with altered mentation, for example, or neurological dysfunction. I'm thinking tick paralysis, snake envenomation patients, botulism patients, patients with tetanus, for example. Just pull that neck, extend the neck gently and pull the tongue forward. Then clean the mouth of blood and mucus. If you can safely do so, then suction the larynx. Now, many of you are probably thinking, I've got a suction unit in the surgery, but not in the treatment area. And when I turn it on, it doesn't really suck really thick, tenacious mucus out of the airway. I'm going to show you a picture of a couple of really inexpensive things that you can get to help you suction the larynx with a greater deal of success and with potentially less trauma and stress to your patients. Then intubate the trachea. When you are intubating a trachea, use a laryngoscope so that you can get to see what's going on in this pharynx and larynx. And then if you need to, then perform a tracheostomy. If there's a massive obstruction in your patient's airway, then you should that's going to take several days in order to resolve, then maybe consider placing a tracheostomy tube. Now, you can see on the slide here that there is an ET tube just here, and you can see there's a swelling here at the base of the tongue. And this poor patient presented to me some years ago now with an abscess on the base of his tongue. He actually had a choke chain that had penetrated his tongue, and it had formed a big abscess there. And this dog had a massive soft tissue swelling. In fact, this abscess that I'm pointing to with the arrow here had actually ruptured, so it's about a quarter of the size it was when we went to intubate this patient. This patient presented to us vomiting and aspirating its vomit, okay, because it had a complete airway obstruction. It was cyanotic on presentation. What I first did with this patient is gave it transtracheal oxygen supplementation. And let me just see if I've got a picture of this. Transtracheal oxygen supplementation when this dog first presented. So what I did was passed an angiocath, so a 14 or 18 gauge angiocath between the tracheal rings, just caudal to the laryngeal cartilages. So in theory, in this drawing, I could have drawn the entrance port into the trachea here, and then the tube would have just gone down here. Now you want to insert your angiocath down to the level of the thoracic inlet. It doesn't have to be in there all the way down into the lungs, because you run the risk of supplementing oxygen just to one lung lobe. So just run your angiocath down to the level of the thoracic inlet. And what you can do then is just attach an oxygen supply to the end of your angiocath and run 100% oxygen through this catheter into the patient's lungs. Unless there's a complete airway obstruction, most patients with compromised upper airways will still be able to exhale out through, say, laryngeal paralysis, obstructed larynx, or like this particular dog that I showed you on the previous slide there that had an abscess on its tongue. He could still breathe out. Breathing in was a big problem for him because the negative intraluminal airway pressure caused the dynamic collapse of his pharynx, and in cases of a laryngeal paralysis, you'll get a dynamic airway collapse in the larynx, and you'll also get some in brachycephalic dogs and animals with with elongated soft palate and stenotic nares, you'll get a dynamic airway obstruction in the nasal passages as well as the pharynx during inhalation. But during exhalation, most animals are able to breathe out okay. And the reason I mention that is that patients in which we are putting a transtracheal oxygen catheter in, we can actually seal off this here with our oxygen hose and run 100% oxygen through this catheter, knowing that the patient's probably going to be able to exhale okay. Now, if you have a patient that has a ball or something stuck in its larynx where it cannot exhale, you're probably not going to want to seal the top of this transtracheal oxygen catheter, because you'll need to provide some sort of a hole for the patients to breathe out of as well when they exhale. But in most patients that don't have complete airway obstruction due to a physical obstruction and that are able to breathe out, you can actually just attach an oxygen hose and get a nice tight seal over your transtracheal oxygen catheter. The other thing that you can do for these patients as well, if they're not too unwell, is to place a nasotracheal catheter into these patients. So that is basically like a nasal oxygen catheter we're going to place in here. Okay, nasal oxygen catheter normally terminates around, I'm just going to change my drawing tool a tiny bit to a pen. Let's change the color, make it stand out a little bit more. For a nasal oxygen catheter, I'm usually just going to insert it down to about this area here, okay, in the nasal passages, and we gauge this this distance by looking at the distance between the alar fold here and the medial canthus of the opposite eye. So that kind of gives us a distance for our tube that we can then pass now into our nasal passages. So that's usually where I'm going for a nasal oxygen catheter. But let's say I've got a brachycephalic dog, okay, and it has elongated soft palate, and it's, you know, it's not looking all that good. Maybe the owners are declining the option to anesthetize that patient and to pass an endotracheal tube. So what you may be able to do is just pass this nasal oxygen catheter into the trachea. So it now becomes a nasotracheal oxygen supply, and that way you bypass this big area here, the soft palate, the epiglottis that might be swollen, and the edematous, the averted laryngeal saccules, and so on. This is not that easy to do in a conscious brachycephalic dog, but in patients that have had brachycephalic airway surgery, this is something that we like to do in the when the patient's under anesthetic, so that we can actually pass a tube into the trachea via the nares, so that post-operatively we can deliver 100% oxygen, or at least oxygen, through our nasotracheal catheter into the trachea, and we can bypass our surgery side. The other point I want to mention is also that patients with laryngeal paralysis, this is a really nice thing to be able to do for them as well, but you will probably need to use some sedation so you can see the path of the catheter. Now, when we are passing these nasotracheal catheters, if you are doing this in a conscious dog, remember, if you're trying to pass this catheter into the esophagus down here, when the catheter gets down to this region here around the epiglottis, oftentimes we're massaging the throat, aren't we? Or we're putting our hand in the mouth to sort of get the tongue to move so the animal swallows. And then as the animal swallows, we push this tube down into their esophagus. What we want to do is a similar thing when we want this tube to end up in the trachea, except that instead of passing the tube down as the animal swallows, I'm going to wait until that animal exhales. And as the animal exhales after it's swallowed, that's when I push the tube down, because that's when their airway is open and I can more than likely get that tube into its trachea. All right. I mentioned before I'm going to help you out with some suction ideas. If you have a big dog that maybe has got lots of saliva and mucus and debris, or a small dog or a cat that's got a mouthful of dirt because it's been traumatized, a big dog versus little dog attack, or a cat or dog that's been hit by a car, you can use small swabs. Okay, but I would put swabs onto some Carmelt forceps or some artery forceps and open that animal's mouth and just gently wipe the larynx and the pharynx with some swabs. They can be mildly moist if you like, just so that that can help grab some grab some of that thick, tenacious mucus and any soil and debris that may be present in the pharynx or the larynx. For large dogs, you might want to use lap sponges, but I always put these things on and hold them in the animal's mouth with some Carmelt forceps or some artery forceps, because if the animal closes its mouth, I don't want my hand in the animal's mouth when I'm clearing out debris from the oral cavity. Okay, so it can crunch down on those forceps and I still remain uninjured. Okay, so that's one of the tips I'm going to give you. The second is that you can buy these things here for about $30. They are really cool little hand suction pumps. They come with usually a couple of size tubes, one suitable for sort of small to medium sized dogs and one that's suitable for larger dogs. They're human products, so they don't have specific attachments for smaller ET tubes, but you could actually put a feline ET tube that'll fit onto the end of this as well. So a size sort of 2.5, 3.5 ET tube you could fit on the end of this. This is just a hand pump here. You just squeeze that with your hand, and any fluid and you can actually generate a fair amount of suction on these. So and the fluid will come in here and into this container, the thick sort of tenacious mucus. These things are relatively inexpensive and they're portable, so you can go to wherever that patient is. You don't have to worry about a power cord powering up a powered suction unit or anything like that in your hospital. So that's something I would definitely look for. The other reason we want to secure a patent airway is to prevent this from happening. This is a radiograph of a dog that had tick paralysis, and he got to us after he lost laryngeal function and he had regurgitated and subsequently aspirated fluids. So all of this white material that you see, so you see these little air bronchograms here and air alveolograms way down in the periphery here. This poor patient has aspiration pneumonia, and when patients have reduced gag and swallow reflex, we really need to be thinking about airway protection in order to prevent this thing from happening. Aspiration pneumonia carries about a 20% mortality rate, so if you can prevent it from occurring in your patients by intubating patients that have reduced or absent gag and swallow reflexes, then we should do that, and do that nice and early in your treatment. So have these conversations with the owner that if the patient has reduced gag and swallow responses, the safest thing we can do is to intubate our patient, because aspiration pneumonia is potentially life-threatening for our patients. So that's the couple of tips that I had to do with airway. Intubate early, okay? That is one of the key things that we can do. Intubate early to relieve obstruction, intubate early to reduce the risks of developing aspiration pneumonia. The second tip, and I'm running behind time because I've spoken now for nearly 20 minutes and I've just covered one thing. The second thing is lung ultrasound. How many of you guys are doing lung ultrasound? And while you're typing your answer into that, I'm going to answer a great question from Zhao. Great to see you again, Zhao. I love it when you come to these lectures. Do we prefer placing these nasal oxygen catheters and nasotracheal with a neck extended or flexed? Usually with a neck extended, just because the tube doesn't have to go around a corner. So try and extend that neck as much as you can within reason. Obviously, if the patient's had head trauma, we do need to be a little careful as to how much we extend the neck in those traumatized patients. So in some of them, we might, if a patient's had head trauma, I'm usually not placing a nasal catheter in these patients anyway, because if they sneeze as a result, they can raise intracranial pressure and can cause some problems, but with potential risk of brain herniation. So I tend not to place nasotracheal tubes and nasal oxygen tubes in patients with acute craniocerebral trauma or head trauma. But if the patient is otherwise just has airway obstruction, just mildly extend the neck. Lung ultrasound. All right, nobody's typed that they're doing lung ultrasound. It is a really nice technique to use. What you're looking at here is intercostal muscles. Intercostal muscles form nice parallel lines. If you were to put an ultrasound probe on the chest wall of a dog or a cat, the first thing you'll see most proximal to the probe is these horizontal lines. These are the intercostal muscles moving back and forth as the animal breathes, that form nice horizontal lines. The next thing that we can see in this patient, okay, is this wavy little line. Now, this wavy little line, I'll tell you right from the outset, is abnormal. Okay, this is abnormal. Normally, what I would expect, and I'll show you some images later on about what I'd normally expect. But anyway, this is abnormal. What I can see here is that there's areas of dark tissue here. Okay, this is dark area. What do we know about ultrasound and areas of blackness on the screen? This is fluid. This animal has pleural fluid, and this wavy line is that we can see here is the edge of the lung, so that we can see the edge of the lung moving up and down as the patient is breathing in and out. How cool is that? Lung ultrasound can help you detect pleural fluid because pleural fluid is going to look black just underneath those horizontal lines. So this is B mode ultrasound. So this patient here has pleural fluid. I'm going to talk to you a little bit about how these things look like. What I'd normally expect to see when I put my ultrasound probe on my patient's chest wall is horizontal lines here, which correspond to the intercostal muscles. Then what I see is a bright white line. Okay, that is the air-pleura interface. Okay, air-pleura interface. And that is a sign that the pleura basically just reflects the sound waves that are reaching the pleura as the pleura either contacts the lung or it contacts the pneumothorax. Then what I see is this air pleura interface gets reflected several times at equal distances away from the chest wall. And these are called A lines. Okay, so we have this bright pleural air pleura interface there in a normal lung. Then we get these A lines repeated. This is a normal looking lung. Okay, the ribs are going to cast dark shadows on either side of the lung that we're looking at. Now, a patient with pneumothorax looks exactly the same, except for one really, really important thing. And that is in a normal patient, what you will see is also usually a little white line that moves back and forth along here. This bright white line, the air pleura interface, will move back and forth. We call this sign the glide sign. And every now and again, you'll get tiny little white streaks. They're really small, okay, sometimes only a millimeter or so. And we call these comet tails, okay? And so this is normal. This is a normal lung. This is a sign that the lung is moving back and forth against the chest wall. And as it's doing so, there's a little bit of lung tissue that's going to cause these little tiny streaks there. Now, sometimes that's hard to see in dogs and cats. Okay, especially cats. I find small dogs and cats, sometimes it's hard to see this glide sign and these little comet tails. So what I'd recommend is that you change your ultrasound mode from B mode to M mode. And in M mode, what you're going to see is a whole lot of horizontal lines, same as you see in the B mode. And then what you're going to see underneath those B lines is pretty much just a mottled sort of appearance. Okay, it's just going to look like grains of sand on a beach, and I'm not drawing a very good beach here. Okay, but this is basically you're going to have essentially what we'd like to describe as waves on a beach. So our horizontal intercostal muscles would be moving like this as waves, and then we end up with a sandy looking beach. That is a normal lung. Waves on a beach is normal. In a pneumothorax, what you will see is the only thing that you will see is waves, and the waves will move from, I'm just going to change my pen color here again, getting all excited. The waves in a pneumothorax will basically just be going all the way down your ultrasound image. You won't get any beach at all, okay? So you're just going to end up with horizontal lines moving back and forth all the way down your lungs. And that is what a pneumothorax looks like on the left. This is what a normal lung looks like in M mode ultrasound on the right. How do we perform these lung ultrasounds? Do we stand the patient up or in recumbency? Whatever way the patient is comfortable. One of the nice things about lung ultrasound, the reason I'm talking about it now, just bear with me a second. The reason I'm talking about it now is that one of the things that can be done and it's quite tempting to do, especially when you're a new or recent graduate and the patient's got maybe an exaggerated breathing effort, is to say, I think I need a radiograph to see what's going on inside my patient's lungs. And if you do that, and a patient that's dyspneic or that's breathing more rapidly than normal, it has deep and rapid respiration, what you'll get is a radiograph of really poor quality. And what you can also get sometimes as you lie that patient on its side to take a radiograph is you can sometimes get a decompensating patient, and sometimes those decompensating patients will die. And then you and I have to make an awful conversation with the owner to tell him, I'm sorry, but Fluffy, your little cat died while we were taking radiographs of its chest because it had really serious lung disease. With lung ultrasound, you can put that ultrasound probe on that patient whatever way the patient is most comfortable sitting in, and that will reduce stress for the patient. It reduces our stress, and we can get a diagnosis of pleural space disease because ultrasound is more sensitive than radiographs in picking up ultrasound and picking up pleural space disease, particularly in the early stages. So as I've mentioned before, what we see typically in patients with pneumothorax is that this image here looks the same as a normal lung, but in M mode ultrasound, what we'll see is just horizontal lines all the way down our patient's lung. In a patient that has a normal lung, we'll sometimes see this glide sign, lungs moving back and forth with tiny little comet tails down here. So if you don't see this, if you don't see the comet tails and you see just these horizontal lines, then do thoracocentesis in your cat or dog before you take a radiograph. The other thing we can also find in the lungs when we're looking at them with ultrasound is fluid within the lungs themselves. So I know that these two patients here have not got a pneumothorax and they don't have pleural fluid. How do I know that? The static images. Okay, I can't see the glide sign at all, but what I can see is vertical streaks coming off that air-pleura interface. So if your patient has these vertical streaks coming from the air-pleura interface, your patient does not have pleural space disease. What this patient has, and I'm just going to make some of those lines disappear, what this patient on the left has is something called lung ultrasound rockets. The English call these B lines rather than ultrasound rockets. The Americans call them rockets and the British call them B lines. Doesn't matter what you call them, but A lines, okay, those are the little lines that are reflected along here. And B lines are the vertical ones. The B lines are the vertical ones that run from the top of your air-pleura interface all the way down the bottom of your ultrasound image. We have got really, really thick-looking B lines in this patient here. We've got a thin one here. We've got massive consolidation of this lung tissue here. What this tells us in this segment here is that we have a lot of fluid in our peripheral lung fields. Now, it doesn't tell us what the fluid is, but lung ultrasound, if you see an image like this, and as the animal breathes, these lines will move back and forth sideways, okay? They'll move sideways. What this tells us is that we have fluid in our peripheral lung fields. That fluid could be pulmonary edema if the animal's got heart failure, could be blood if the patient's got pulmonary contusions and has suffered trauma, okay? It could be due to pus if the animal has just aspirated, has aspiration pneumonia, but it tells us that we've got fluid in our lungs. The number and thickness of these B lines or lung ultrasound rockets correlates directly with the amount of fluid in the lungs. So here's just a bigger image of what I had in store for you there. I've mentioned before that fluid in the chest cavity looks black. So if you see an ultrasound and you can see this sort of image here, that means you've got fluid. Don't take a radiograph of this patient. Put a thoracocentesis needle in and draw out as much fluid as you can to improve your patient's ability to tolerate further intervention. And this is really what I come out to point number 3, and that is, if you have pleural space disease that you pick up with a lung ultrasound, do thoracocentesis before radiography to help reduce the chances of your patient deteriorating. We're going to pop our needle. I normally go about halfway between ventral and dorsal in these patients. So here I've drawn it nicely around the junction between the upper and middle thirds. But honestly, if you put your needle thoracocentesis here, halfway between the top and the bottom, you're still going to get fluid. You're still probably going to get air from your patient. Your thoracocentesis will relieve respiratory compromise and discomfort in your patient, and your patients will do better as a result. Always drain both sides. We go in intercostal space between ribs 5 and 6, or 6 and 7, or 4 and 5 and 5 and 6. It doesn't really matter too much. If you're using an ultrasound, then you can actually put your needles in where the animal has the most fluid or the most air that you can detect in that chest cavity. Always drain both sides and drain as much as you possibly can. Just note, okay, here's an interesting conundrum. This dog here, he presented to me with having been hit by a car, and he wasn't breathing all that well. And I did a lung ultrasound on him and thought, he's got a pneumothorax. Okay, I couldn't see any glide sign at all here when I put my ultrasound probe here. He's got a pneumothorax. So in I went with my needle. I did a thoracocentesis. The dog's respiratory rate came down. The dog was looking better. His color improved. Pulse oximeter reading went up. And about 15 minutes later, it got worse again. The patient was breathing worse. Okay, this became more labored, became more tachypnic. Pulse oximeter reading began to fall. So I did another thoracocentesis 20 minutes after the first one. 20 minutes later, I'm doing it again. Going, what is going on with this particular patient? It was only on one side of the chest. The other side of the chest actually remarkably looks quite good. There was a little bit of, I had a few B-lines, so the animal had a bit of pulmonary contusions going on, but something wasn't quite right with this dog, and he was deteriorating before our eyes. So I elected to take some radiographs, and this is what I found. And this was a stomach that had herniated into the chest cavity and was filled with gas. The dog couldn't burp that gas up, and as a result, the stomach would just refill with gas and cause compression on the lungs. So yes, absolutely, Jal. This is a diaphragmatic hernia and stomach dislocation into the chest cavity. I think I have the lateral radiograph here, which was rather spectacular. We knew that this point in time that we needed to take this dog to surgery straight away. And indeed, that's what we did. I did perform another thoracocentesis just before anesthetic induction, so that I had lungs that were as inflated as possible before I induced anesthesia. Once I got the patient intubated, I did another thoracocentesis so I could shrink down that stomach as much as possible before we went to surgery itself, okay, during the surgical preparation time. So these patients are really intense patients, but I just put that up not to scare you at all, but just to say that not all pneumothoraces come from a popped lung. Some of them can sometimes come from a herniated stomach. Point number 4, let's talk about shock. This just made me think of a song, but I'm not going to sing it, okay? I've got a terrible singing voice. Let's talk about shock. But, okay, I started. I shouldn't have. Shock, okay, results in vasoconstriction and vasodilatation throughout the body. If your patients, and I'm going to focus on dogs because I'll talk about cats a bit later on. If a dog gets hit by a car or attacked by a dog, or it suffers horrendous hemorrhagic diarrhea, it will go into shock because of acute volume loss, acute sympathetic nervous system stimulation, and adrenaline release from the adrenal glands. That will cause differential vasoconstriction and vasodilatation. What do I mean by differential? I mean that blood vessels will become dilated in organs that are responsible for the flight, fright, fight response, the heart, lungs, brain, and voluntary muscle, to help that animal to get out of harm's way. Blood flow in our organs that are not essential for the flight, fright, fight response gets decreased. We have decreased blood flow through the gut, the liver, and the kidneys. So early on, patients with shock can appear to have really good pulses because blood is concentrated in these 4 organs here. Okay, it's concentrated in these 4 organs: the heart, lungs, brain, and muscle. Over time, oxygen supply to the gut, liver, and kidneys reduces, and so does the blood supply and the oxygen delivery to the smooth muscle cells that are causing vasoconstriction in the gut, liver, and kidneys. And so one by one, we tend to get vasodilatation in the gut, liver, and kidneys as shock progresses. And this will lead to a patient that then has uh, not great pulses and really good blood flow to its heart, lung, brain, and muscle, our patients will begin to look dull, okay, and mentation. Their pulse quality will become more poor. They'll become weaker as blood begins to redistribute out throughout the rest of the body. Things to try to avoid doing if you see a patient with shock is to avoid giving high doses of methadone, say the 0.2 milligram per kilo of methadone. Methadone will mask symptoms of shock, okay? You won't be able to detect a change in respiratory pattern all that well in your patients. You won't be able to detect a change in mentation all that well in your patients that are traumatized. So use a shorter acting opioid analgesic if you can. My preference is fentanyl, or you can use a lower dose of methadone if that's all you have in your practice. But don't just give methadone as a treatment. Oh, my patient's got a really rapid heart rate, he's panting, or he's got a fractured leg, maybe he's really painful, I'll treat him with methadone, and forget to treat him with intravenous fluids. The other thing to not do is just to say, well, he's a little bit shocky. I think he's in shock a little bit. So I'm just going to give him twice maintenance fluids therapy, so maybe 4 or 5, 6 mils per kilo per hour for a couple of hours. That's not nearly enough in terms of fluid rates. Or if you say, oh, look, I think he's just stressed, let's just give him more sedation or more pain relief. Let's ignore those clinical signs or write them off to something else. What should you do? Well, we've got to diagnose shock. Treat shock diagnosis as a diagnosis. The diagnostic test is our eyes and ears and a bit of machinery every now and again. Remember, early in shock, we have an adrenaline rush. The patient's got great pulses and good mentation because blood's only going to the heart, lungs, brain, and muscle. Mucous membranes are bright pink. Got a short capillary refill time and the patient's mentation is good. But as shock wears on, the adrenaline rush will wear off a little bit. The patient will become more dull. Their pulses will transition from being good to being normal to being weak. Their heart rate is generally still quite rapid, and their mucous membranes transition from looking quite nice and pink to looking a little bit pale and not so good. So if we make a diagnosis of shock, of hypovolemic shock in the emergency patient, we need to treat shock. How do we treat it? With lactated Ringer solution. Yes, you can use other types of fluid, but lactated Ringer solution is generally what we're going to reach for 99.9% of the time. In dogs, we're going to give our patient 10 mils per kilo in 10 minutes. And then I'm going to reassess my patient and see if the signs of shock are still there or not. And if the patient still has rapid heart rate, weak pulses, poor mentation, then I'm going to give them another bolus of 10 mils per kilo of lactated Ringer solution in 10 minutes. And I'm going to do that for maybe 3 or 4 boluses. And then I'm going to stop, because if my patient's still not recovered from shock after about 3 or 4 boluses of IV fluids, then I need to look for a reason why. And I'm going to talk about that in a second. Some references suggest you could substitute one of those boluses of lactated Ringer solution for a boluses of Voluven to prolong the effectiveness of the fluid therapy, so the fluid lasts for longer in the blood vessels. However, there's a question mark there, and that is because in all of the studies in trauma patients have not found an improvement in survival in humans, whether you add synthetic colloids to your treatment or not. So we don't really appreciate an improved survival rate, even though in theory there might be a theoretical benefit to using that. In terms of how else we can treat shock with fluid therapy, if the patient's bleeding, obviously we've got to compress the source of bleeding. So if it's external, there's a bleeding through an open wound, or if there's a fracture, we can put a big soft bandage over that fracture site to try to compress the site of bleeding. If there's internal bleeding into the abdominal cavity, we should put an abdominal wrap on our patient. And if our patient is bleeding into its abdomen or we can see fluid in the peripheral lung fields on our lung ultrasound after trauma, we presume the patient's bleeding into its lungs. Abdominal bleeding and pulmonary contusions bleeding and bleeding into the head, okay, so craniocerebral trauma, all have shown benefit in the human medicine field from injection of tranexamic acid. Tranexamic acid is an antithrombolytic drug, so it makes the blood clots in your patient last for a little bit longer. And so tranexamic acid is something that we routinely use in patients with blunt abdominal trauma, particularly if they have evidence of abdominal bleeding on ultrasound using fast ultrasound. A fast abdominal technique is a really useful one to learn. If you haven't learned it yet, then consult a really good reference. You could use aminocaproic acid as well. I don't have a lot of data on aminocaproic acid, but it acts in a similar way to tranexamic acid as far as being an antithrombolytic medication. Tranexamic acid, 10 milligrams per kilo IV over 20 minutes, and then another 10 milligrams per kilo IV over the following 4 hours. We're in our early days in the veterinary medicine field with regarding tranexamic acid injections in dogs. The doses may well increase as we gain more evidence over time, given that dogs tend to have a much more highly active thrombolytic system than people. Now, tranexamic acid hasn't been used reliably in cats except to induce emesis in cats, so it's not something that we're using in cats. Now, I mentioned before, what if you give your patient IV fluid therapy, treat them shock rates of IV fluids for half an hour, 40 minutes or so. You've given it tranexamic acid, maybe because you suspect abdominal bleeding or you've seen evidence maybe of some fluid in the lungs on a lung ultrasound after trauma, and you think maybe my patient's got pulmonary contusions. I should slow down the rate of bleeding for that patient. My patient's looking worse, or maybe it hasn't changed at all, and you're going, Phil, this shock treatment just doesn't work. No response is actually a response. It's telling you that something else is going on in your patient. What's going on? Well, that's for you and I to work out as veterinarians. Get your nurses involved in this as well, or your technicians. Your patient could have pulmonary contusions. This is a normal lung on the left. This is what a lung looks like, a post-mortem photograph of a lung that has pulmonary contusions. Lungs that are filled with blood can't be aerated terribly well. Your patients will suffer from decreased oxygen transfer into the vasculature, and they will maintain a state of high sympathetic nervous system tone, and they will stay in shock if they've got severe pulmonary contusions. So grab your lung ultrasound, look at the lungs. If you see evidence of those B lines in a trauma patient and you haven't given it tranexamic acid, then go for that. If it's a dog, if it's a cat, just support that patient as best you can, but you may need to intubate these patients and start to ventilate for them if you find them. So this is a photograph I wish I put in a little bit earlier, but this is what you're going to see in a patient that has pulmonary contusions. These lung ultrasound rockets, these streaks that are running down from dorsal to ventral in our lung ultrasound. You might have a patient that is not responding to shock because it's got a diaphragmatic hernia. This is a contrast radiograph of another dog whose stomach has been herniated in. Sorry, this is this is a dog whose stomach is herniated into its chest cavity here through a diaphragmatic hernia as well. Your patient may have heart disease. It might have an abnormal cardiac rhythm. Check out the heart rate on this patient here, 198 beats per minute. This dog has atrial tachycardia. How do I know it's got atrial tachycardia? I'm going to tell you a little bit about that in 2 nights' time. So in 2 days' time, I'm going to take you through some of the things I wish I'd known, and one of them is about ECG interpretation. Okay, so this patient has nice, tall, narrow QRS complex. This means the patient's got a disease in its heart rhythm that starts with the word atrial. The next thing I notice with my patient is that the T waves here and the P waves are really close together. And in one place in this particular tracing, the T wave is buried inside the P wave of the subsequent ECG complex. This was a P in T phenomenon. So this patient has atrial tachycardia. This is a ECG tracing from my own dog, bless him, Siggy, who died a few years ago now, who got pancreatitis and developed sepsis as a result of acute severe necrotizing pancreatitis. So he had atrial tachycardia. You might have a patient with big, wide, bizarre QRS complexes. We're going to diagnose this patient as having ventricular tachycardia. He's got also wide, bizarre QRS complexes here as well. Occasionally we'll see a P wave, but these QRS complexes are not normal. So this patient has ventricular tachycardia. You can have patients with normal QRS complexes and paroxysms of ventricular tachycardia. If you've got these conditions, ventricular tachycardia, you've got to look for the reason why the patient may have these problems. Sometimes it can be sepsis. Sometimes it can be that patients have serious electrolyte abnormalities like hypokalemia or hyperkalemia. It could be that your patients have calcium disorders, hypercalcemia or hypocalcemia. They may have severe acid-base disturbances. They might have dilative cardiomyopathy, hypertrophic cardiomyopathy if it's a cat. So we need to look for the reason why our patients have these problems. Your patient might have had a bleed into its pericardial sac. The actual size of this poor dog's heart was probably about this size here. The rest of this pericardial sac here is filled with fluid. So, an ultrasound of this patient might give rise to being able to detect the patient of pericardial fluid here. So if that's the case, we need to then perform a pericardiocentesis. And I know as a new or recent grad, you're thinking, oh my goodness, I've never done these things before. We've all been in that situation. Grab a textbook, phone up a colleague, phone a friend, give us a call even here at Vet Education. If I'm awake, then I'll answer the phone. I can help you out. But there are some really good references. I put up a protocol in a procedure in the Vet Education webinar library for those of you who are webinar members on how to perform pericardiocentesis. It's a short video, really helpful in times of stress to be able to have those kinds of resources helpful. So drain that pericardial effusion. Guess what? If you do that, your patient's symptoms of shock will start to disappear. Your patient could be bleeding into its abdomen, so do an ultrasound of its abdominal cavity to see if you can see free fluid. Free fluid looks black, surrounded by, the white fluffy organs or omentum and other things that are in the abdominal cavity. Your patient could be bleeding from a fracture. Patients with long bone fractures can bleed up to 20 mils per kilo out of a long bone fracture. So if you have a patient that's got a fracture, then try to bandage that fracture to try to provide a little bit of pressure on that too. Your patient may have sepsis. Okay, this is what happened to my dog Siggy when he failed to stabilize for treatment for shock. When he had shock, he had sepsis. Okay, so we then need to manage sepsis. And so then you go to a resource and you find out how to treat sepsis in the most expedient manner possible. I will tell you right now, completely free of charge, that one of the best things you can do early on if you suspect your patient has sepsis is to begin antibiotic therapy, 4-quadrant antibiotic therapy. Even if you just give an enkephazoline or amoxicillin clavulanic acid, get them started on antibiotics. There's about an 8% increase in mortality for every hour that antibiotic therapy is delayed in human beings with sepsis. We don't have the data for dogs, but we expect that it's quite similar to that. Your patient may also be painful, so do a pain score on your patient as well. I mentioned don't give methadone big doses straight up while your patient's got shock, but certainly don't ignore pain. So we need to make sure that we have our patient on adequate pain relief and use local anesthesia as well as continuous infusions of fentanyl, ketamine, lignocaine. If you haven't got fentanyl, use methadone as a bolus injection, then get your patient on ketamine and lignocaine as continuous infusions. Use local anesthesia as best as you can to provide complete analgesia to areas that you are able to treat. Now, the dose for tranexamic acid, 10 milligrams per kilo, you're exactly right. So thanks for that question. Okay, what do we do after our patient has been treated for shock? We've got them on fluids. We take a big sigh of relief. Our patient's shock has resolved. What fluid rate should we turn our patients down to? Should we maintain them on shock rates of fluids? Should we put them on twice maintenance because they might need a little bit extra? Well, the short answer to your question that I've just asked for you is that you turn your fluid rates down to maintenance. There's a reason for that. And that is, if your patient presents to you in shock and you give it shock rates of fluids like lactated ringer solution, 3/4 of your lactated ringer solution will leak out of the blood vessels into the interstitial spaces within 1 hour of you giving that fluid. So we actually only end up with 1/4 of the lactated ringer solution that we initially gave our patients still sitting in the intravascular space. That puts our patients at a huge, at a state rather, in which they have a massive fluid overload. So total body water of your patients is now much, much higher than it was when they presented to you. So our patients have a net positive fluid balance. So we don't need to have our patients on twice maintenance fluids in the immediate period after shock, because they have all of this extra fluid that we've given them that's now sitting out in the interstitial spaces. And if I have my patient on twice maintenance fluids after I've treated it for shock, all I'm doing is putting more fluid in the interstitial spaces. Why is that a problem? Well, it's a problem because evidence suggests that patients with more interstitial fluid have a worse outcome following trauma. So treat patients for shock, then back off on your fluid rates down to maintenance rates. And this is particularly important in patients that have had bleeding, pulmonary contusions, head trauma, bleeding into the abdominal cavity, and so on. Get that fluid rate down to maintenance rates, okay? No higher than maintenance rates. Sure, if your patient's dehydrated, you've got to rehydrate them then as well. If they've got maybe parvovirus enteritis and they're in shock, maybe we'll turn them down to maintenance, and then we add on top of that a specific calculated volume of fluids over 12 to 24 hours to rehydrate our little puppy, and then we turn the fluid rate down to maintenance rates again. Now, number 7, the triad of death. This is actually specifically the trauma triad of death. There are 3 things that are going to increase the rate of mortality in a trauma patient. One is hypothermia. One is metabolic acidosis, and the third is the presence of a coagulopathy. Okay, so these 3 things are 3 things that we don't want to go anywhere near. So when you are resuscitating your trauma patient, make sure that you focus on getting that patient's body temperature slowly back up to normal. Okay, you want it above sort of 37 and a half degrees Celsius. Okay, you don't want it hanging down around 36 to 37 degrees, because that will produce a patient that has a greater tendency to bleed. Okay, coagulopathy is associated with worse outcomes. So run a clotting time and repeat your clotting times in your trauma patients if you notice that your prothrombin time is becoming prolonged, or your APTT is becoming prolonged, or if you're doing activated clotting time that's becoming a little bit prolonged. Typically, our rule of thumb is if the PT is becoming more than 1.5 times longer than the normal range for a dog, then we would recommend transfusing that patient with fresh frozen plasma to normalize its coagulopathy at the same time that we're warming our patient up. Acidosis is something that we obviously want to avoid, and usually if you're focusing enough on your fluid therapy, most acid-base disturbances tend to go away. But if you have a patient who has sustained metabolic acidosis, look for the reason for that as well. I'm just going to answer a couple of questions. Trish just asked a question, sorry, but how long do we wait before we turn the fluids down to maintenance rates? When my patient's symptoms of shock have begun to return to something close to normal. They don't have to be normal. I don't have to have a normal heart rate, but I want my blood pressure to be at least normal. So somewhere between about 100 and 120 millimeters of mercury, and a heart rate that is approaching normal. So in dogs, maybe it's approaching 140, 150 beats per minute. I don't want it 180 or 200 beats per minute. And in a cat, maybe 150 beats per minute for a heart rate, 160 beats per minute for a cat. And I want my blood pressure for cats particularly to be normal. So between 100 and 120 millimeters of mercury. And I would want that to happen, okay, once I've treated my patient for shock, and it shouldn't take any more than 30 or 40 minutes. If it is taking more than that, I go on that hunting trip to find out if my patient's got heart disease, abnormal heart rhythm, if they're bleeding anywhere, all those other things we talked about. And I fix those things up. And once those things are fixed up, then I'll turn my fluid rates. Well, actually, as I'm on my exploratory journey, okay, if my patient's not responding to intravenous fluids to treat for shock after 40 minutes, I'll oftentimes turn them down to maintenance rates until I find out what's going on with the patient. And then if my patient needs another bolus of fluids, I give them 5 or 10 minutes worth of a bolus of fluid to treat them for shock once I've begun to normalize or evacuate the the pleural space disease that might be present, or the pneumothorax or whatever it happens to be, I'll turn that fluid rate down to maintenance rates, usually after the first half hour, 40 minutes of shock, and then maybe after, again, if I need to give them another bolus for 10 or 15 minutes after I've corrected whatever I've found has caused them not to respond for shock, then I'll turn them down to maintenance rates pretty much as soon as they've stabilized. Now, Laura's asked a great question. What is a maximum fluid rate we administer to a dehydrated cat? Are you comfortable administering 50 mils an hour for 24 hours if that's what's calculated based on fluid deficit, like hydration deficits plus maintenance and losses? I really like that question. I'm going to talk about cats in a little bit, Laura, but the short answer is no, I don't like high fluid rates in cats because they don't tolerate them very well. I'm happy to take 48 hours to rehydrate a cat, okay, rather than 24 hours if I need to, because cats just do not tolerate high rates of intravenous fluid for that long. Nutrition. All right, nutrition is so important. Okay, malnutrition can develop very, very rapidly in patients that are traumatized or suffering from illness. If we're healthy, and hope that you're all healthy, if we stop eating now, and I probably should stop eating, but if I was to stop eating now, I could survive for weeks without eating. As long as I was hydrated and had water, I could survive for weeks. I'd just do a lot less and I'd lose my muscle bulk and everything else. And the same would be the case for a dog or a cat. However, if you superimpose illness on top of starvation, you can suffer from protein and calorie malnutrition within 1 to 2 days. And the problem with malnutrition is it reduces the rate of wound healing. It makes us more likely to get infections. We get reduced respiratory function. Our respiratory secretions become thick and inspissated. Our airways become blocked with thick, tenacious mucus. We have reduced cardiac function. We lose muscle mass in our heart, and our intestinal villi begin to atrophy. And so when we then feed our patient again, they don't tolerate that food. So starvation, simple starvation slows our metabolism down. We get gut stasis and everything else. But illness does the exact opposite of what starvation does. Illness wants to ramp everything up, increases metabolic rate, more production of toxins, increased demand on the cardiac and respiratory systems, and increased risk of infection. So we're going to ramp up our immune system. So it's the exact opposite thing that a starving patient actually needs. So early nutrition is associated with better outcomes in humans and animals. Nutrition reduces adherence, absorption of bacteria and their toxins, and we get better gut function, reduces the extent of intestinal destruction during illness and injury, and we get less nausea. So you can actually help your patients that are vomiting with parvovirus enteritis all the time just by feeding them something. Early nutrition improves wound healing, immune response, cardiovascular and respiratory function. We get less complication rates after surgery and better survival. In septic peritonitis in dogs, there was a study looking at 45 dogs, retrospective study, and they found that those patients that were fed early had shorter hospital stays by 1.6 days. Parvovirus enteritis, interesting study, okay? They had 15 cases in which they had no NPO, so no feeding until vomiting ceased, versus early enteral feeding, another 15 patients. All early enteral nutrition groups survived, and 2 in the NPO group died. So all the early enteral nutrition groups survived, 2 in the NPO died. And the enteral group, they had earlier clinical improvement and significantly more weight gain. So these are in parvovirus puppies where they're starting to feed within 12 to 24 hours. So feed the gut, and you don't need much. As little as 25% of the animal's resting energy requirements will be sufficient for maintaining gut integrity and reducing those bacterial adhesion and all of that sort of stuff as well. We're nearly there, and I'm sorry I'm going a tiny bit over time, but cats. I love cats. Cats are brilliant. Who here likes cats? I think they're a fascinating species. Not only are they adorable, but they have an incredible wiring system inside their nervous system that is so completely different to that you find in dogs. It is absolutely fascinating. So we're going to talk about cats. What's so different about cats? By the way, this is a cat It looks like a healthy cat, but it could be a cat that's just about to die. We don't know because cats hide things from us. And that's one of the things I really would like to impress on you, that cats hide things from us. Let me just tell you about a couple of studies in septic peritonitis, okay? In the literature that I reviewed over the last 20 years on cats with septic peritonitis, abdominal pain was present in less than half the cats with septic peritonitis, based on all of the retrospective studies that have been published in the last 20 years. Things like blood glucose and lactate may help inform prognosis, but at present, some cats will have sustained elevations in blood lactate level and they'll survive. Other cats with normal blood lactate concentrations will die. We don't actually have a really good way of telling whether or not a cat is going to live or die based on blood glucose and blood lactate concentrations in circulation when they have septic peritonitis. So we don't have good indicators as to whether or not they're going to live or die based on those parameters. Appropriate and early antimicrobial therapy can improve outcome. This goes back to what I was talking about before with patients with sepsis. The earlier you start antibiotic treatment, the better your patient's outcome potentially can be. So if there's a suspicion that your patient's got septic peritonitis, start them on antibiotic therapy. Appropriate antibiotics in this case is going to be antibiotic therapy that treats the common bacteria that you see in the gut. So amoxicillin would be perfectly fine to use in the cat. Even amoxicillin plus metronidazole plus or minus enrofloxacin would be fine, but at least start amoxicillin in these patients. In some cats, the cause of septic peritonitis can't be identified. At surgery, in some cats, they haven't been able to find anything that's caused the problem. So the biopsy, always come out with something. Biopsy the gut, the liver, other organs that you think may be a little bit suspect. But overall, the prognosis for septic peritonitis in cats can be quite good. Up to 70% of cats will survive. Now, Giles just asked the question, is fever or hypothermia common in septic peritonitis in cats and dogs? It's quite common in dogs if they've not been on antibiotic therapy prior. In cats, fever was not necessarily a common finding in cats, and I'm going to explain why when I talk about shock in the cat as well. Jack's just asked the question, how long would you wait with an inappetent patient until beginning to feed them via a nasogastric tube or nasal-esophageal tube? You want to be making a nutrition plan within the first 12 hours of that patient coming into hospital. So at the very least, work out how many calories you're going to need to feed your patient. And then between that 6 to 24-hour period, that's when you need to begin feeding that patient. So passing a nasal-esophageal or nasogastric tube in that time period is something that you need to factor in. There is a bit of Murphy's Law. Sometimes you'll pass a feeding tube, and the patient will eat the very next day, or they'll eat 5 minutes after you've just placed the tube, and you think, well, wasn't that a waste of time and effort and money? But if you hadn't put that tube in, would that patient have eaten? Well, I've seen patients that have looked like they're going to eat, they start to eat. So the decision to place a feeding tube has been delayed for 12 or 24 hours. And 24 hours later, the patient's still not eating that much, but they're eating a little bit. And so there's a discussion that goes on. Should we place a feeding tube? Should we not? The best thing you can do is just place the feeding tube within the first 24 hours and then begin feeding that patient. The decision's made then, and your patients will do so much better. It's absolutely awesome to see them. All right, let's look at cats again. What about gastroduodenal ulceration and perforation? Here's the most common signs. Getting back to Giles' question about fever, when cats have serious disease, lethargy, anorexia, and vomiting are the most common clinical signs when you've got gastroduodenal ulceration and perforation in cats. Okay, abdominal pain can be present in as few as 20% of cats. If this was me and I had a gastroduodenal perforation, I'm sure I'd feel a lot of abdominal pain. I've seen these in dogs. Dogs are not happy if their intestines rupture. They're really painful. Okay, peritonitis is a painful thing. Cats, 20% of them go, oh, I'm feeling a little uncomfortable. 80% of them just go, I'm just going to sit here and not eat, and I'm just going to be lethargic and anorexic. Could be any cat, couldn't it? Could be a cat that's just having a bad day. But a cat also that's anorexic and lethargic could be a cat who's got a raging septic peritonitis. Neutrophilia is common, and anemia may be present if you've got significant bleeding. Radiography was not helpful, except in cases in which you had actually perforated the intestine, in which case you got a little bit of gas appearing up around the liver, okay, in the cranial abdomen. That's where you get free peritoneal gas. So look in front of the liver, between the diaphragm and the liver, and in the dorsal abdomen. So given the vague symptoms, a patient that comes in with lethargy, anorexia, and vomiting in the cat needs a pretty decent workup. Okay, a really good workup to allow detection of gastroduodenal ulceration and determination of underlying cause, some of which was non-steroidal, some of it's tumors and other things like that as well. I'm going to talk about shock in the cat now. I gave a lecture actually just while I'm talking about the acute abdomen in the cat, on the acute abdomen in the cat last year. And again, if you're a vet education webinar member, then that is up in the webinar library for you. And we go through a whole bunch of other conditions, including colonic torsion, GDV, and a whole bunch of other things too. Okay, so what about shock in the cat? The clinical signs of shock in the dog, there's tachycardia, bounding pulses, then getting weak pulses, mucous membranes that are bright, then getting slightly more pale as things go on. They don't happen in the cat. Cats look like dogs do when they've got decompensating shock. They've got hypotensive, but oftentimes their heart rate is slow, and they oftentimes have low body temperature. So a cat in shock is going to have hypothermia more often than not. And there are a whole range of complex neural circuits in the cat that are the reasons for this. There's a whole bunch of reflexes in the feline ventricle, the atria. Noradrenaline release from the sympathetic nerves leads to centrally mediated hypothermia, and that hypothermia, it reduces noradrenaline release from the central nervous system, and we get a blunted response to shock or sympathetic nervous system outflow. We also get an increase in parasympathetic nervous system outflow secondary to a reduction in that sympathetic nervous system outflow due to hypothermia, and that then produces bradycardia and vasodilatation as well. The less fluid that a cat's heart gets returned to it in shock, okay, the slower the cat's heartbeat. Due to a whole range of neural circuits within the feline atria and the ventricle. So the clinical signs of shock in the cat, remember three things: hypotension, bradycardia, and hypothermia. We had a question before about when do we turn fluids down to maintenance. In dogs, we wanted our blood pressure and things like that to be normal. In cats, we want these things to be normal. Notice that hypotension and hypothermia were two of the things that we really were concerned about. Certainly hypothermia was one of the things in the triad of death. Hypotension is going to lead to acidosis, which is also in the triad of death. So hypotension and hypothermia in cats, we definitely need to treat. So how do we treat it? We treat it with lactated ringer solution. We treat it in cats with 7 mils per kilo over 10 minutes because cats have got a smaller blood volume than dogs do. Okay, so 7 mils per kilo, not 10 mils per kilo, but 7 mils per kilo over 10 minutes. Repeat that every 10 minutes until you get a response. Our response or resuscitation endpoints are blood pressure between 100 and 120 millimeters of mercury, our heart rate around that 160, 180 beats per minute level, and body temperature. We want to raise it to 36.7 degrees over the first 30 to 40 minutes, and vascular tone will improve after that point. Then we slowly improve our patient's body temperature up to the normal range. So that's our endpoints for shock. So small volume, 7 mils per kilo in 10 minutes. Do we use tranexamic acid? Not yet in cats, okay, for bleeding. If our cat doesn't respond to treatment within half an hour, there's a problem. We've got to look for it. These patients have got blood loss in their abdominal cavity. They've got third space losses into their gut or a body cavity, or they're really sore. They might have anemia, so get a PCV. They might have pleural space disease. They might have head trauma. They might have sepsis as well. So we have to go and look for these problems. They might have heart disease, hypoglycemia, and some patients, they might even have a relative cortisol insufficiency. And that's a topic for another lecture. So the last thing I wanted to mention before we sign off there is communication. If it is so important for us to communicate everything that we see and hear about our patient, from the nurses and technicians that are reporting to us about decisions that we're making for the animal. We need to communicate that to the people who are looking after our patient, the nurses and technicians and kennel hands who are looking after our patients with us. We need to communicate things to the client. We need to communicate what the client has said to our colleagues as well, and write everything down. Okay, write everything down. Communication is so, so important. If you have a nurse or a technician who comes to you and says, look, Phil, this cat that you've just admitted, he's not looking terribly good. He's still breathing really fast. And I'm busy doing something else, and I've got another patient that I'm tending to. I need to really listen to what that person is telling me. Really listen to what your colleagues are talking to you about. If they're not happy with how that patient is doing, that's really important, because as you and I know, if we see a patient with something wrong with it, we oftentimes feel that we've got to tell somebody, right? And there's a mindset that says this is serious enough that I have to tell somebody about it because I'm really not happy about it. If we're being told stuff as veterinarians by the nurses and technicians that we work with, that they're concerned about a patient's level of pain or their respiration or whatever it happens to be, then we need to listen to what's being told to us, and we need to take that seriously and evaluate it really seriously. Otherwise, we can end up with a lot of problems. That is what I had for you. Thank you so much for coming along tonight. I'm super happy to take any more questions, and I think that you guys have been absolutely fantastic tonight. I've loved your questions to date. Now, there was one that I missed out on, as in any suspected pathology, non-steroidals. Yes. So non-steroidals or antibiotics can mask any temperature dysregulation as well. I totally agree. So that can be a problem for us, depending on whether or not you've got antibiotics or anti-inflammatory medications on board as well. I'd really like to thank all of you for coming along tonight, and please type in your questions. And I'd also like to thank Charisma and Alpana for setting up the webinar room and for fielding any technical problems that you might have had this evening. Laura, you've asked a question. Sorry to reiterate, would you say the max fluid rate you'd be comfortable giving to a cat would be 7 mils per kilo? So 7 mils per kilo in 10 minutes for no longer than about 30 to 40 minutes to treat it for shock. So Laura, that's the first part of the question. Now, the second part of your question, I think, was if you've got patients that are really dehydrated and you've got maintenance hydration and ongoing losses, how fast would I be happy to give my patients fluids? Actually, I think the rate you've written there, 7 mils per kilo per hour, is actually not too far off the maximum that I would be happy to. If you put a healthy cat on 10 mils per kilo per hour, it will begin to get pulmonary edema after a few hours. And I've seen this happen in patients who've been maintained on the old-fashioned traditional surgical rates of fluid therapy, and the rates haven't been turned down for 2 or 3 hours, and those patients end up with a lot of extra pulmonary fluid. And so, yes, around about that 7 mils per kilo per hour, I think it's a probably prudent place to have as your theoretical maximum rate of fluid that you're going to give your patient while you're rehydrating it. When you're treating them for shock, we're just using 7 mils per kilo in 10 minutes, and we might repeat that 2 or 3 times for, 3 or 4 times, 30 to 40 minutes or so to treat them for shock, and then we're pulling them down to maintenance rates after that. Awesome. Hey, thank you, Pia, for your comment. That's lovely to get that. If it was your new grad, that's really, really awesome. We have coming up for you tomorrow night, we're switching tack a little bit. We have a clinical psychologist, Dr. Michelle MacArthur. She is talking on practical tips for enhancing well-being. We know that well-being in our profession is something we really need to look after. We need to look after ourselves and our colleagues. Michelle is an absolute pleasure to listen to. You're going to get a lot out of hearing her speak. These are life skills for the rest of your life. Skills for the rest of their life skills. They're really important life skills. Me and myself all tied up here. They're really important life skills that will help us not only in our professional life, but our personal life as well. So tune in, same time, same channel tomorrow night to hear Dr. Michelle MacArthur talk about practical tips for enhancing well-being. This has been the focus on recent graduate symposium for 2022. Thank you so much again for coming along tonight for the session. We will see you again tomorrow evening. I hope you have a lovely remainder of your evening or your day. We'll see you tomorrow night. Thank you.